anything just yet. Everything's working?
I haven't tried it yet, but I have tried it before, and that always
Okay.
works. I think it should be fine.
I don't have any fears whatsoever. So we're live streaming on Instagram Live. We live stream on YouTube, and then this will be available on YouTube as well. So you can share the link. We'll send it to you guys afterwards. All right.
Good. Thank you. Great.
Thanks so much. All right. So it's 4. Why don't we just go ahead and get started? Welcome, everyone. I see some people are still signing in. This is Tumor Talk. This is a collaborative effort between the Journal of Neuro-Oncology and Lenox Hill Neurosurgery, where we discuss recent publications in the journal and try to highlight really the reasoning, the results, and the rationale behind them. And so we're super pleased today to have your group from Munich, right? Which is one of our few international events. And so I'm super excited about that. Dr. Sheehan will be a couple minutes late. He will join us. And so why don't we just get started? You guys will have 15 minutes or so, give a presentation of or just discussion about the paper, and then we'll open it up to the forum to interactive discussion, and we'll ask some questions.
All right, so I think I need to start to share my screen, right?
Now's the time.
All right. Okay.
How are things in Munich otherwise? Good?
It's much later than in New York, I think.
I know, I'm so thankful for you guys doing this.
Well, it's easier to get everyone in front of the screen.
Yeah.
Okay, can everyone see it?
Absolutely.
Yeah. Perfect. So first of all, thank you very much for the invitation and for the opportunity to present our study, which has been published in the Journal of Neuro-Oncology recently with the name Surgical Treatment and Neurological Outcome of Infiltrating Intramedullary Astrocytoma WHO grade 2 to 4 in a multi-center retrospective case series. So short introduction, without going too much into details. Infiltrating intramedullary astrocytoma in the adult population is a rather rare case in incidence. The incidence itself ranges between 0.05 and 0.1 per 100,000 persons per year. Already well known, the prognosis is rather poor. The median overall survival ranges between a few months to 1.5 years, depending on the publication and literature that we researched on. Patients normally present in the outpatient department with a very rapid neurological deterioration, and the time span of the symptom duration, at least in our study, depended highly on the WHO grade of the tumor. This is a short imaging for an example. One patient with a diffuse astrocytoma WHO grade 2 on the cervical spine between C4 and C6, and then another case presentation of a young patient with an intramedullary tumor mainly located at the cervicothoracic junction and intramedullary contrast enhancement, who exhibited glioma, WHO grade 4. So why did we came up with this idea? Why did we think about performing such a study? So first of all, we realized there's very limited evidence on how to treat those patients surgically. Also on how to treat them after surgery. So what kind of adjuvant treatment can we offer to the patient? And then the questions, how do they do after we treated them, either surgically or with adjuvant treatment? So how did they perform neurologically and from their clinical status? So what we aimed in this rare entity is to describe contemporary treatment. So how would we aim to treat them, and to describe how they perform after surgery and treatment, so the clinical outcome of those very rare entities of infiltrating intramedullary spinal astrocytoma, graded WHO grade 2 to 4. What did we perform, or what are our methods? We performed a multi-centered study, including 5 different neurosurgical departments, including Germany, Austria, and Switzerland. To name them, it was Berlin, Munich, Hamburg, Innsbruck, and Geneva. We performed a retrospective cohort study and included all patients which had a diagnosis, so a surgically treated and diagnosis, spinal intramedullary infiltrating astrocytoma, WHO grade 2 to 4. The time horizon was 2008 to 2019, and we specifically excluded the pilocytic astrocytomas because they have a very distinct outcome and a very distinct nature, and they were non-infiltrating, so we didn't include them at all. What kind of data did we assess? We looked at the surgical technique, looking first of all at the approach that was used, and also at the extent of resection, dividing between gross total resection, subtotal resection, tumor debulking, and open biopsy. We looked at the pre- and postoperative neurological status using the McCormick grade and the Karnofsky Performance Status Scale. We looked at how did we treat them afterwards using radiotherapy and chemotherapy, or did we apply a wait-and-see therapy? And we looked how they performed, so the median survival and also the clinical outcome. Those are the first results. First of all, describing the extent of resection, showing that already half of the patients, or nearly half of the patient, underwent a biopsy, and approximately half of the patient a subtotal or gross total resection. About 13% underwent a tumor debulking. Those are the demographics also described in the paper. We included a total of 40 patients, 11 WHO grade 2, 12 grade 3, and 17 grade 4 tumors. Median age over all groups were approximately 41 years, and most patients were male. If we look at the location where the tumor was mainly located, we saw that it was mostly at the thoracic spine, also then at the cervicothoracic junction and thoracolumbar junction, but mainly in the thoracic part. About 25% of the patients underwent a previous surgery, so it was not the first diagnosis, and most patients, or the median at all, showed already a moderate impairment on the McCormick grading scale. The p-values show that between the different groups, or between the WHO groups, we didn't see any significant difference. This shows, it's not included in the papers, we did it now for the presentation. It shows a little bit the clinical status preoperatively, postoperatively, and at follow-up. And what we aim to focus on this slide is mainly that we had an amount of patients that already presented with mild or intact clinical function, describing that they were independent preoperatively, and the outcome afterwards. And what we can see is that the two patients, and we know that we only included 2 patients with gross total resection, initially presented with a fairly, or with a good clinical status. And we can see that after surgery, they deteriorated. So all of them worsened after surgery. If we look at the subtotal tumor resection, there were 4 patients who underwent subtotal tumor resection, and half of them worsened after surgery. And if we look at the group who underwent the biopsy, we see that 10 patients were preoperatively independent, and only 2 of them ranged afterwards to the moderate or severe impairment. At the follow-up, most of the patient deteriorated, as we know from the nature themselves. So we know that on clinical outcome, patients tend to deteriorate rather fast. Before surgery, as I mentioned it before, we saw that most patients had a moderate disability, so median McCormick grade of grade 3, and almost 40% had a grade 1 or a grade 2 McCormick grade. After surgery, we saw that only 25.6% still had a grade 1 or a grade 2 on McCormick, and that 3 patients suffered from severe impairments, so a grade 5, which we didn't have before then. What we're going to talk about now is about the clinical status and look at the Kaplan Myocurves. Before, we saw also the adjuvant treatment. So what did we do with the patients after diagnosing the different tumors? Most of them, as described, underwent a combined therapy, so a radiation therapy with a chemotherapy. And the 4 patients undergoing only radiotherapy were the tumors graded WHO grade 2. And in the group, which is depicted here as none, but was a wait-and-see therapy, was either a WHO grade 2 tumor or 1 patient that was just too disabled to undergo combined treatment. Those are the molecular markers that we investigated in the tumors. I marked 2 different ones because they played a role in our statistical analysis to describe first Ki67, which was significantly dependent on a WHO grade in the median in WHO grade 4 of 20%, in WHO grade 2, 3.5%. This is also described in other studies and other publications, but was replicated in ours. And RTRX loss of expression was not really significant, but it was very close to it, and it's probably because of the small sample size that it didn't fit for 0.05. Those are the median survivals that we investigated for our patients. We see here a median survival of 7.4 months for the WHO grade 4 tumors, despite what we already mentioned in the introduction, that the prognosis is very poor and dismal. The Kaplan Myocurves also presented in the paper are the first curve that we can see on the upper part is the WHO grade, which shows, of course, a strong correlation with the survival itself. On the lower curve, we describe the extent of resection, so gross total resection versus subtotal resection in the red line, tumor debulking and biopsy, which are the very, very close lines that we can see at the very bottom. We didn't see any significant difference between those factors. But what we saw and what was significantly or very strong significance was the preoperative McCormick grade that is depicted here on the upper image, where we can see that the two groups, mild and intact, has a very high survival rate, and the severe and paraplegic patient a rather low survival rate. The progression-free survival was also here dependent on the WHO grade. So what do we describe? And the first of all, we need to discuss the limitations, which are, of course, the retrospective nature of the study itself, but also, which is kind of natural due to the entity itself, it's very rare. So we have a small sample size, even if we included 5 different centers. We saw also that the McCormick grade, the preoperative one, not the postoperative one, had a prognostic value on the overall survival, which was described in the curve earlier. We found 2 markers which seem to have an effect on the overall prognosis and the WHO grade, which was Ki67 and loss of expression of ATRX. And then the probably most important slide, summing up and describing the results themselves. So what we saw was that patients who underwent an open biopsy to get the diagnosis or to perform the surgery only to know what kind of entity they suffer from, they tended to remain clinically independent, so having a McCormick grade 1 or 2. This was in a fair contrast to the patients who underwent a more extensive tumor resection, such as the gross total resection or the subtotal tumor resection. Even though we didn't see a significant influence on overall survival of the extent of resection, we only just had 40 patients, so it can be possible that it's still dependent on the sample size as well. And how we do it now in our hospital, or how we ended up concluding in our paper, is that for the time being, at the moment, due to the dismal prognosis, we conclude that the treatment of those infiltrating rather high grade intramedullary astrocytoma should be either limited to the surgical diagnosis to get the adjuvant treatment also done, or as we describe it in the paper, to short tumor debulking. And that's the summary, and I thank you very much for the attention and stay open for questions.
Thanks so much. That was great. This is a horrible, tough disease, and like you said, extremely rare. But every time one comes about, it's always a pretty devastating diagnosis and prognosis. I think that your paper is extremely informative and relevant, and I think the results really make you think as you do these surgeries, what are you hoping to achieve here, and raises a lot of questions. So I think it's a great first step, and I think fabulous job. First question I always have about, or after I read it, the first question I had was basically, how has this changed? So you're doing a biopsy, but are you still doing, a laminectomy, the entire extent of the tumor to decompress the spine to allow this to progress and grow? Or do you find that that's not changing, prognosis that well? Or are you just doing now smaller biopsies, interlaminar laminotomies to go in and just take tissue and get out? Has it changed what you're doing clinically?
Should I?
Whoever.
So we also looked at the different approaches used, which was very heterogeneous between the different centers included. But we tended, like, if we really see a spot that we get or that we can approach easily, we would choose that and either do hemilaminectomy or laminoplasty to get there.
Maybe I can add, being the most senior one on that, and that is being initiated by me because I tend to be an aggressive surgeon, but with intramedullary astrocytomas, I've always been very reluctant to do more extensive surgery because I see I don't change I mean, it's an orphan disease, so we don't know a lot. But the impression I have, I don't change the fate of those patients, but I crippled them, just to be blunt. I crippled them for the last months they have. So I'm a lot of favor of just doing a biopsy, and whenever I see, you can see that from the pictures, it's an astrocytoma. So I don't even consider doing laminoplasties or putting in duroplasties or whatever. So I just do a tiny hemolaminectomy, do a biopsy, and that's it, and wait for the result. I know that's more or less what I feel that is right. These figures here, they don't prove it, but at least they give me some idea that I'm not completely off. Honestly, I don't know how to prove that, because it's a rare disease. Even if we have a prospective data gathering, it would take ages.
You're right. Yeah. I think you're absolutely right, Dr. Meyer. You would have difficulty powering a study to prove it, and your study is one of the best studies out there now. It reflects contemporary treatment paradigms, and you've done a very nice set of neuropathological markers and looking at this. I was intrigued more in that the success that you've had with higher functional status patients who come in better off, and also the grade 2 patients seem to do really well. I don't know if we can go back to that, but I mean, rather than focus on the negatives, what I took from this was that we can really make some, that these grade 2 patients can actually have reasonable length of survival, and that we're hopefully providing some benefits, not just from the surgery and diagnosis, but with the adjuvant treatments that you've outlined. So there are going to be some patients that are going to have an unintended consequence of a surgery, but I agree, you don't want to make the treatment worse than the underlying disease, and I think that's kind of what you've shown here.
I think you put it on the spot. It's not the surgery you should discuss. It's the way how aggressive we are with adjuvant therapies. I mean, if it's grade 2, we have, I think, all 5 centers. I mean, we know each other very well. So we kind of not so heterogeneous on what we offer as adjuvant therapy. We might be somewhat less homogeneous in what we do surgically. But the bottom line is, if you are more aggressive in adjuvant therapy in, let's say, lower grade infiltrating gliomas of the medulla, you're achieving something. It's a little bit like in the brain, okay, where we change from being rather conservative with grade 2s and becoming more aggressive. And I think that's the key point.
I was impressed too. It looked like your methylation status in the lower grade patients was a little bit higher than I might have expected for a similar cohort of brain comparable tumors. Maybe there's some opportunities there where the adjuvant therapy is really even potentially more meaningful. Although granted, with limited statistical power, but with an extraordinarily rare type of neurological problem or neurosurgical problem.
Yeah, I think you guys you guys have the opportunity here with 5 systems, with 5 hospital systems contributing to pool the data together, which is fantastic. It's something that I think we miss out on a lot in the US, where we have major centers, we have populations, but with rare diseases in particular, we struggle to combine everything together. So the multi-center aspect is fantastic. Is there a role for subtotal resection? Do you look at a certain case and say, you know what, maybe I'll take some of this out, it's necrotic, or there's something there? Is there a point where we'd argue to do it, or are you at this point committed to just biopsying and get out, like you said?
I'll let the others talk now. Maybe Masha wants to talk. You have to unmute yourself. Du bist stumm.
I think you're muted.
Du bist stumm. Du musst dein Mikrofon anschalten.
Yeah, no, sorry. There is also a question in the chat concerning, so the question is, what is the merit in tumor debulking in spinal astrocytoma? So I think we had also a couple of patients in whom we made a total resection, but both of them were patients in whom we suspected an ependymoma, in fact. So we didn't know that it was an astrocytoma. So we went for the total resection, and both of these patients deteriorated after the surgery. So I think the only point when is it possible to think about extended debulking or subtotal resection is if you have a syrinx, for example, or you can make a kind of decompression just to put the syrinx away. The only way, I think, this is the only reason you can go for, or you can remove more from the tumor than, for example, a normal biopsy. But in the majority of cases, we do the biopsy and then go for adjuvant treatment like radiation and or combined therapy.
Yeah, this is, if I may add, a classical internal discussion that we have in our department. And I've come completely away from even considering debulking. But some of my attendings, I mean, they just replicate what I had done ages ago. So, and I don't know if I'm completely right. So this is the problem that I have. It's a difficult question. If you ask me, if you don't do a harm with debulking, it's fine with me.
So what do you think about the idea that the preoperative McCormick grade matters? Were you able to look at whether or not changing someone's McCormick grade matters? Does reducing someone's McCormick grade actually make you have a worse prognosis? Because the preoperative one, you know, people come to you at varying degrees. Maybe it's, I don't know, someone who comes earlier, maybe they have a slower growing tumor, right? They notice it over time and they become more concerned because it's slower growing. I'm just curious, does the actual injury from the surgery contribute to a less prognosis or a worse prognosis?
So from the statistical point of view, we looked at it and we looked at the neurological deterioration as a factor itself. And interestingly, it did not, because we saw that some of the patients, mainly those who had a biopsy first, some of them recovered also until discharge. And it did not, most of them declined anyway at follow-up. So it didn't really change the natural history.
So to me, that suggests this is an intrinsic tumor issue, which goes back to what Jason's pointing out, which is that we need to focus on our adjuvant care, right? There are tumors that are going to be more amenable to specific adjuvants, whether it be molecular markers that we need to better describe, better characterize, or future treatments. I mean, it's the tumor that's the issue, and it's high price real estate, and that's where we run into problems.
I think this is the key point. I mean, if anything is quite clear from this study, I mean, with all the retrospective small sample size issues with statistics, this is not a surgical issue.
Yeah,
completely opposite to what we see in the brain. I mean, where we learn that it makes a difference, but this is a matter of volume, most probably. But within the spinal cord, I mean, the key issue is how you treat the tumor or how effectively you treat the tumor apart from surgery.
Yeah. Well, I think, it's location is everything. If this was a thalamic glioma, you're not going to, you're still going to just biopsy. So
same
location.
Yeah, that actually, if we touch upon, I think someone's asked that question in the chat.
Yeah.
Does location play a part in deciding to debulk? But I guess I would maybe broaden the question and say, does location play a role in your overall treatment management for these patients? And I realize it's statistically limited study given the rarity of the disease, but do you think about these patients differently based upon the location, and if so, how?
Not really. I mean, looking at the pictures, you basically are pretty sure if it's an ependymoma or not. You have a margin of error,
Sure.
And then I mean, obviously, if you have something in the cervical spine, it forgives you a lot more than if you have it mid-thoracic. So that may play a role, but So even if I had doubts what it is and it's mid-thoracic, I would just consider a small biopsy. If it's in the mid-cervical and I don't know exactly what it is, I might even consider doing a debulking, but that's so vague. I don't know if you can, if you think differently or quite the opposite, it's fine with me. That's I mean,
just fielding questions from the audience here, and I thought we would just sort of broaden the question, since it doesn't look like anyone's advocating aggressive debulking or resection.
Well, the problem is, if you look in the literature, there are people, advocating doing that, and that's something I would be very cautious, to be honest. I mean,
yeah, actually, you're just anecdotally, this paper came out about the week prior to me getting one of the worst grade 4 cervical astrocytomas I've ever seen. And I, honestly, I took it to heart and I was like, yeah, I can't, I'm not going to hurt this person. Like, there's no chance of me doing this and having a great outcome here. So we biopsied, we got a diagnosis, grade 4, and, she's off to treatment, and that's all we could really do. I think is the right thing to do. And so I think it was nice to see this paper. So,
if you compare the timing between your surgical procedure and then when you typically would initiate the next round of treatment, the adjuvant therapy, are you usually waiting a couple weeks, or how does that work in your centers? I know there may be some variation.
Yeah, I mean, I can tell you what it is in Berlin and Munich as soon as possible. That doesn't mean weeks. It's more like within 10 days.
Gotcha.
Enough for wound healing, and that's pretty much it, right?
Yeah, but it's a small thing, right?
Yeah.
Right. I mean, if you do a biopsy,
it's smaller. Yeah. Actually enables it earlier. Well, listen, we try to limit these to about 30 minutes. We'll take one last, allow the audience to reach out one last time, but really appreciate your guys' contribution. Really appreciate you being here and staying up late for us and, helping us out on the international front.
Yeah,
and it's a fantastic paper. I think there's a lot of work to be done from the molecular end of things, and you guys started that discussion as well. And so hopefully you can keep that momentum going.
We'll do that. Thank you very much for having us.
Outstanding paper. Looking forward to more contributions from you. Thank you so much.
Yeah, sure. Thank you. Good night.
Bye.
Oh, goodbye.
All right, everyone, have a great night. Bye-bye.
Yeah, you too. Bye-bye.
Bye-bye.